Good afternoon, good morning, ladies and gentlemen. So, yeah, we all talked about CXL in bits and pieces during all parts of the conversation. So, I'll basically, CXL with LASIK is associated in two ways. One, when you're trying to treat an ectatic cornea and bring it more to a regular shape, I won't be dealing with that. I'm basically talking about CXL when you combine it with LASIK in certain circumstances. So we have talked about different ways of understanding whether the cornea has been strengthened or not. So now there are only very few direct ways of knowing whether corneal strength has been achieved. We all know that once Dr. Theo Seiler started CXL.
Make it slide show.
Yeah, once he started CXL, it was combined with porcine corneal pictures were shown, and the Young's modulus was combined and that shown, and that's how we decided that the strength actually increases. But whatever other parameters or instruments we are using right now, like the ORA, it indirectly measures, whereas these two modalities, the Brillion and the confocal microscopy, are what directly tells you what's happening inside the cornea. So I'll just go into a bit of these two modalities. Now, what is Brillion microscopy? Each molecule in the cornea has intrinsic thermodynamic changes happening, which are transferred into acoustic modulations, basically. And it is these acoustic modulations that change the frequency of light that hits the cornea. So there you have light coming down, the near infrared laser light from the Brillion microscope coming down, and these acoustic waves modulate the light and bring about a frequency shift, which is detected by the Brillion spectrometer. So that is how the entire process works, and this frequency shift is comparable to the longitudinal modulus of the cornea, which is different from Young's modulus. Unlike Young's being a physical quantity, this is not a physical quantity, but nevertheless it determines the compressibility of the cornea. So if you have a higher Brillion's modulus, the less compressible the cornea. So this is the measure that is given by Brillion's microscopy. And when you have a microscopy that tells you that after CXL, the anterior part of the cornea has a significant increase in the Brillion modulus compared to the posterior part of the cornea, it means that the cornea has strengthened in that area, and these are some of the spectrometry images following CXL to the cornea. Now, the second part was confocal microscopy. So, confocal microscopy actually tells you what's happening inside the cornea. Now, these are microscopic images of the cornea 1 week after CXL, and you can see that the superficial part of the cornea. So, here you can see the depth from the surface, and the superficial, the epithelium, the subbasal layer, and the LASIK flap area. So, this is all CXL with LASIK. So the LASIK flap area, these are not affected by the procedure. Whereas once you go into the stroma, beneath the stromal bed, you can see apoptosis. There's keratocyte apoptosis and decrease. And as you go further deeper, you see that the density of the keratocyte nuclei increase because the effect of CXL wanes off. You go into the posterior stroma, it's even less. And in the endothelium, it appears only as pseudoguttae. That means basically some transient endothelial edematous changes. So there are no permanent changes. Now, this is what is happening when you're doing CXL combined with LASIK in compromised cases. Now, what are those cases? Basically, the patients who are considered to be good candidates are those which have absolutely normal cornea, but they have thin cornea. So that if you want to do an ablation and you want to feel safe about it, then you can add CXL to the procedure. In very high patients who may require a high dioptric correction, because we know that these patients tend to regress or may go into ectasia even with apparently normal cornea. Hypermetropes also, it's supposed to provide stability, and some people have also used this as an indication for people who don't directly have keratoconus or any signs of keratoconus but may have conditions that predispose to it, like a family history or maybe some form of systemic allergy, eye rubbing and all that. Now, how does it differ from the classical Dresden protocol? You're trying to treat all the areas below the flap basically. So we are trying to leave the flap out because the flap absorbs riboflavin and decreases the efficacy of cross-linking. So you're trying to treat the areas below that. Short exposure time and a high fluence, high energy that you pass initially. But the total energy given to the cornea is much less than what is going in via the Dresden protocol. So if the Dresden gives 5.4 joules per cm square, you are trying to bring it down to somewhat in the range of 1.8 to 2.7 joules per cm square. So another thing that should be remembered is a normal cornea is being irradiated. There are no signs of keratoconus as of the time that you're doing the procedure. And secondarily, this is to do as a prophylaxis and not as a treatment. So what is the procedure like basically? Once you lift the flap after, this is a femto-LASIK flap that's been lifted, and the laser ablation goes on. So I'm doing this on the Schwindemaris 750. So once the flap has been lifted and the plumio actuator brought down and centration has been achieved, the ablation carries on in the stromal bed. So now this flap, which has been lifted and kept apart either in a taco formation or open, is excluded from the procedure of infiltration or by riboflavin. Once the treatment is done, you put riboflavin on the bed of the flap and spread it and put this flap back, so that whatever absorption of riboflavin happens into the stromal bed. So this is the classical protocol described by Candelopoulos. He was one of the first to do the procedure. You take out all the excess riboflavin and then irradiate that part of the cornea for a short duration. The amount of energy that has been used varies from 10 milliwatts to around 30 milliwatts, but for a very short duration of time. So 60-second exposure, I don't have that machine, so that's why I use 9 for around 5 minutes. So 60 seconds of exposure to riboflavin, and then around 80 seconds of exposure to UVA is what is classically proposed. Now this is an epithelium on procedure, mind you, because you are putting the LASIK flap back. Now what were the results given by the doctors who performed them? So as far as the visual acuity is concerned, everyone, right from when it was done by Candelopoulos to one of the latest reviews in Asian Eyes by Lowe et al., have shown that there is an increase in the visual acuity. That means the number of people who achieve 20/20 are slightly more with this procedure compared to LASIK alone. The second thing was refractive stability. We all know there is scatrometric stability, dioptric stability with CXL. Now, the refractive stability was also supplemented by the amount of epithelial hyperplasia that happens, showing that it is much less, around 9 microns on an average in LASIK extra compared to around 3 microns in LASIK extra compared to around 9 microns in regular LASIK. Now, what could possibly be the adverse effects? Now, you have a young patient with an absolutely normal endothelium subjected to CXL. So, yes, whether there is any effect on the endothelium. Now, even when you do hypermetropes, you get to know that there is more consistent flattening in these patients and there is less amount of regression. So endothelial cell loss is virtually nil in these patients. There is no adjuvant tissue damage, especially you're concerned about the limbal stem cells all around, they are not damaged. But it has been shown that some drugs like fluoroquinolones and antifungals don't permeate into a CXL-linked cornea as much as into a normal cornea. There could be some amount of corneal haze, and what happens if you need a further treatment on such cornea? Again, these are gray areas. Now, there have been some new insights by Lin et al. Because we have found that CXL can be either oxygen-mediated or non-oxygen-mediated. So that's how they distinguish into the two types, type 1 and type 2. And that they have shown that initially it was believed it's completely oxygen-mediated, but now it has been shown that a large part of it is non-oxygen mediated, and that is why epithelium on procedures are also at least 1/3 as efficacious as epithelium off. And of course, they have suggested a concentration control method where you keep on adding riboflavin to the procedure. So ectatic corneas, I had told, briefly mentioned before. Now, what are the points to ponder when you're doing CXL along with a normal in a normal cornea along with LASIK? So does it mean that LASIK is basically unsafe and you need to do every cornea? No. LASIK is safe. Only thing we as of now don't know how to predict cornea that go into ectasia. Secondly, how long will the effect of this cross-linking last, because the cornea keeps on remodeling? And last of all, how long does ectasia take to appear, because this procedure has been around only for around 2 years or so, and we need to go a long way before determining how efficacious it is. Thank you very much.